just fitting with our conversation as we wrap up that what kind of impact this service has made to an average Australian's life.
Even being able to talk to a fellow clinician, over the telephone, is an amazing tool and gives confidence. Where if you had no connection, then it would be terrifying. Public health experts were trained on, diseases like infectious disease. They haven't been trained on diagnosing technology harms to public health.
Flying doctors and nurses of Australia is something that came out of motorization and something a perfect example of an outreach, public health outreach based on the kind of country and the continent that Australia has. So, talk about it because it's been a while that I wanted to talk about it, and it's just fitting with our conversation as we wrap up that what kind of impact this service has made to an average Australian's life.
Absolutely. I think it's a very good point because when we talk about public health and public health advances, we're often focusing on centralised populations, urban populations in big cities, because that's where, the vast majority of people in developed countries certainly are living. And we forget about, even in developed countries, those people living in remote areas. And I guess in Australia, we have a massive outback. And I've actually worked as a doctor periodically in the outback. And suddenly, having access to communication becomes absolutely critical. I mean, when you're, thousands of kilometres from the closest hospital, trying to manage complex patients and keep them alive. Even being able to talk to a fellow clinician, over the telephone, is an amazing tool and gives confidence. Where if you had no connection, then it would be terrifying, literally terrifying. Because obviously, often you can be walked through even problems you haven't seen before by other colleagues. And similarly, the flying doctor service, taking doctors and nurses to the patients in these remote areas has been transformative. And I didn't realise how transformative till I was working in a place called Fitzroy Crossing. It's up at the top of Western Australia. So it's about 2,000 kilometres from the nearest city. And, I had an extremely ill patient, who was on the verge of dying. And so I rang up the flying doctor service and they said, we'll try to get a plane to you first light tomorrow, because again, the flights generally don't fly at night because of navigation, and also even to fly a plane there from the closest hospital, you're still talking like 10 hours of flying time. It's such a distance. And suddenly you realise, they say, so if you can keep the patient alive for the next 24 hours, we hope to get as long as the weather is okay and everything else, we hope we'll be able to get a plane in and evacuate the patient for you. But you have to keep them alive for the next 24 hours. So then it's just like every hour I hope the weather's clear and I hope that plane, because this patient really needs, care and attention in a big centre. So even the flying doctor service has limits, but it's life-saving. There's no question. And without that, I think remote communities, potentially would collapse. Because if people can't get healthcare, then as they get older, they wouldn't actually be able to stay in those remote areas. It it would be too life-threatening. But by having those services potentially available, they can stay there longer. They can stay there with chronic diseases, with their families and their communities. If we didn't have services like the flying doctors, those people would have to be evacuated, once they get to a certain point of age or morbidity, they would have to leave. And, that can be devastating. So yes, technology has made amazing impacts both in developed countries for remote patients and, of course, developing countries where a vast majority of the population, such as in India or Tibet or Nepal, still live in extremely remote, disconnected villages that may not even have roads to get to the closest hospital. And so, drone technology for flying medicines into these places, even if there's no road or the road's been washed away by an avalanche. Nowadays, of course, you can send a remote drone in with medical care packages or with vaccines. That wasn't available even a few years ago. So technology, is having really massive impacts, particularly for the most disadvantaged people, because that's what we forget. As I say, if you live in the centre of New York, well, you've got access to everything there and within a kilometre or so. But we often forget that doesn't mean that people living remotely have access to the same services. And we can talk also about medical manpower, and I think that's a future discussion. But, even in the US, there are people who can't get medical attention because there's no doctors anywhere near where they are. So even in a developed country, there can be issues about, equality of access to medical care. And technology obviously is one of the ways we can actually try and compensate for that and equalise access. Maybe not perfectly, but like telemedicine, we now do a lot of telemedicine in Australia. With COVID, it became, you could suddenly get reimbursed for doing telemedicine, which previously we couldn't. So the government, because doctors couldn't see patients in person, suddenly they had to allow them to do it through telecommunication. And of course, then you get a system built around that. And so increasingly, again, telemedicine will be a way of delivering care to remote communities, which we couldn't do before, not because we didn't have the technology, but because our payment systems and our bureaucracy had not factored those technologies into the equation. But, perhaps the upside or the good side of COVID was it did force a lot of changes in terms of, bureaucratic adoption of technologies to improve public health care.
Dr. Petrovsky, briefly, with the kind of technological and communication infrastructure we have now, how much advantage are we taking of it in terms of improving our global health indicators, say in terms of percentages, in your personal opinion?
So it's frustratingly slow. So the technology is fast, but medicine as a whole, because it's part of a bureaucratic, massive government system, is insanely slow. So I would say we probably only utilise 20% of the current technology. And I guess, a good example in my field, endocrinology, would be the GLP-1 agonists. So, in the last year or two, we've seen this explosion of excitement about using GLP-1 agonists, to treat obesity and diabetes. I was prescribing GLP-1 agonists 25 years ago. These are really old drugs. And the world has only started to embrace them in the last couple of years, and then talk about them as blockbusters and life-changing. And you're going, why weren't people picking up on this 25 years ago? I was certainly prescribing them to all my patients as wonderful drugs. They were available. They were approved. and no one was using them. Why has it taken 25 years for people to wake up, the medical profession to wake up? I mean, it's extraordinary, but it's a real example of just how slow, the medical profession is at implementing new technology, whether it's new drugs or whether it's, new communication devices or new medical devices. There's this enormous inertia in the system for all sorts of reasons, but bureaucracy is a big one. But it's not the only one. Doctors are conservative. They like to do what they've always done. They're not quick to necessarily change and adopt new things. So because of that, it is frustrating for those of us, as I say, who like to be at the cutting edge. I think that the bottom line is, look, technology always has positive and negative public health implications. We should work out how to use technology to get the maximum effectiveness of our positive public health campaigns. But at the same time, look very carefully at what are all the potential public health harms and try to mitigate those as much as possible, so that the new technology is used for good and we limit its harm. So I think we need public health experts who are experts in technology, and I think that's one of the areas you're obviously focused on. But I think most public health experts were trained on, diseases like infectious disease. They haven't been trained on diagnosing technology harms to public health or to health and correcting them. So it's almost like a whole new profession we need of public health experts on social media, on neck injury from too much computer time, on eye injury, so from too much screen time. So we need to build a whole workforce to monitor and, as I say, alleviate any harms that are a result of the technology. Because, as I say, that's inevitable, that technology can always have harms as well as benefits. So that's my message. Let's build a workforce out there and, make sure that the technology is used for good.
When we come back for the next episode or the next topic, this technology and the underpinnings of the technological change driving the global health will always be a part of our upcoming topics as well. So I have to thank you very much for being with us throughout this discussion that comprised 4 parts, Professor Petrowski.
It's a pleasure.